today. I think that's the topic that I'm going to cover. I want you guys to make a note if possible, okay? Just in case there is an issue with uploading the video or something. So maybe just make the note. We'll start with definition first. Stroke is defined as any sudden onset of a focal neurological deficit. Any sudden onset of a focal neurological deficit is stroke until proven otherwise. This is more or less a practical definition because, when we administer TPA, we are fighting against time. It is only approved, well, it is FDA approved only for 3 hours, but we use it up until 4.5 hours. So you really do not have time to get imaging and trying to figure out, because the shorter the door to needle time is for TPA, the better the outcomes. And you are just going by clinical presentation with acute stroke patients. So the natural question that comes to mind is, okay, what if patient did not have an ischemic event, meaning the focal neurological deficit is from some other problems. For example, a hemiplegic migraine can cause focal neurological deficit, or a Todd's paralysis, which usually is a paralysis that follows a tonic-clonic seizure. And if the seizure was not witnessed, this may be considered as a sudden onset of a focal neurological deficit. So what if you ended up giving TPA to those patients? That's fine. Usually the complication rate in somebody without an ischemic event, the bleeding complication is actually very low. So it is still better to give TPA to some of these patients, which is actually usually very rare, rather than not giving them TPA or wasting time in getting the testing to confirm the diagnosis. This concept is recently changing, where many of the places are actually doing MRIs in the ER and making TPA decision based on that, especially if they do not present within the time frame. We'll probably talk about that later during this lecture. So stroke is defined as any sudden onset of a focal neurological deficit. 1 minute the patient is fine, the next minute patient has some weakness or sensory symptoms or visual problems. That is stroke until proven otherwise. So that's the definition of stroke. Ischemic stroke. I mean, of course, you classify the stroke into ischemic stroke and hemorrhagic stroke. This lecture is about ischemic stroke. I'm going to cover hemorrhagic stroke during next lecture. So we are going to focus on ischemic stroke. As the name suggests, it's because of the decrease in the blood flow. We tend to classify ischemic stroke based on Toast classification, which was proposed probably more than 2 decades ago. And it provided a basic template which we use even in present day to classify the stroke. And there are 5 main categories of ischemic stroke. First one is what we call large vessel atherosclerosis. Second one is small vessel disease. These are also referred to as lacunar strokes because of their smaller size. Third one would be cardioembolic strokes. Fourth one would be other causes of stroke or other known causes besides these 3. And the fifth one, what we call cryptogenic stroke, meaning we don't know what caused the stroke. The risk factors for large vessel atherosclerosis and small vessel diseases are basically the same, like hypertension, diabetes, history of smoking. However, the clinical presentation is very different. And I think that is why I'm saying when you go to that neuroanatomy PowerPoint, it has some differentiating features on how you can differentiate large vessel versus a small vessel disease clinically. So when patients present with a large vessel atherosclerosis, so large vessel basically are in the anterior circulation, or we often call this carotid system, are your internal carotids. MCAs, ACAs. Those are the main ones. And then in the posterior circulation, or what we call vertebrobasilar circulation, those are your vertebral arteries, basilar artery, and then your PCAs, posterior cerebral arteries. Um, Large vessel, if we talk about anterior circulation, MCA, supplies what's called cortex. Cortex just means gray matter of the brain, basically, which controls your higher functions, higher mental functions or processing. Whereas small vessel disease are branches that often arise from large vessels, but they do not supply cortex or the gray matter. They actually mainly supply white matter. And because large vessels supply the cortex in these large vessel strokes, clinically, you will often see what we call cortical signs. Cortical signs. When you go through the neuroanatomy PowerPoint, I have listed all the cortical signs in that PowerPoint. But some of the most common cortical signs that you will see are aphasias, which probably will be the most common one that you see. Visual field cuts may not always be cortical. It may also happen from extensive white matter injury, but it is still considered a sign usually of a large vessel stenosis or occlusion. Apraxias, for example, considered large vessel sign. The other common thing you will see clinically would be something like extinction or neglect, gaze deviation to one side. Remember, patients with stroke always look towards the side of the stroke. So if the stroke affects the right hemisphere, the normal function of the right hemisphere is to push the eyes towards the opposite side. And now because it's not working, the left hemisphere takes over. And your eyes are usually looking towards the side of the infarct or the stroke. So gaze deviation to one side. These are all signs, cortical signs. There are many more, but these are the most common ones that you will see clinically. But if you want to know all of them, maybe just refer to the neuroanatomy PowerPoint. So when you see these cortical signs, clinically, you can actually classify the stroke as a large vessel involvement um, or a large vessel stroke. Whereas small vessel disease, because they do not supply the cortex, they will not have these cortical signs on clinical exam. So now, next time you see an aphasic patient, it's not just about, oh, cool, this is aphasia, like I read about it, but I'm seeing the aphasia now. But no, it actually gives you an idea about classification of stroke. That this probably is a large vessel stroke. Um, Small vessel disease, on the other hand, as I said, will have absence of cortical signs. Small vessel disease or lacunar strokes are defined actually based on neuroimaging. When they did not have MRIs, they used to classify this clinically into various different categories like pure motor stroke, pure sensory stroke, sensory motor stroke. So pure motor meaning they just have weakness, pure sensory meaning they have tingling numbness on one side, sensory motor meaning they have both. There is another one called dysarthria, clumsy hand syndrome, meaning they have mild hand weakness and they have slurred speech. The problem with this is that many times when, after the advent of the MRI, when they started doing MRI, let's say, for example, in somebody who had a pure motor stroke, it was not actually a small vessel disease. They actually had a pretty big infarct in the motor cortex. So technically, it would not be considered a large vessel disease. So, if you can get a neuroimaging, that is the best way to classify these. And in that case, small vessel disease or lacunar strokes are defined by their size, which is usually less than 1.5 centimeter in maximum diameter. Usually the MRIs that we do here and at most institutes, each slice is about 5 millimeter thick. So the small vessel or lacunar infarct that you see on the MRI should not be more than 3 slices, as long as each slice is 5 millimeter. Okay. on the MRI. And of course, clinically, they don't have any cortical signs, the small vessel disease. So these are your lacunar strokes. The most common sites of involvement are internal capsule or corona radiata. For people who don't know this, all of this is in neuroanatomy PowerPoint. They may even have it in the pons from the perforators of the basilar artery. So that's your small vessel disease. The risk factors for both are the same, as I said before. Cardioembolic strokes.
Can I interrupt you?
Yes.
About the question about small vessel lacunar infarcts, you said that it could occur inside the capsule, meaning you have more of a pure motor kind of deficit. But you said it wouldn't involve the circulation in the basilar or the vertebral or any other thing.
No. So basilar artery stroke is different than the perforators of the basilar artery. So if this is the basilar artery gives out multiple small perforators like this, which are called paramedian pontine branches. So basilar stroke would be if you have a clot here, and then a huge part of the brainstem, even cerebellum, may be affected. Whereas a small vessel disease would be a clot somewhere around here, for example, which will then cause a very small area of infarct in the pons. Does that answer your question?
Yes, thank you very much.
Okay. Um, Cardioembolic strokes, uh, on neuroimaging, it may take two forms. One is, we all know this, is that it can involve multiple vessel distribution. Correct. For example, if it's a large vessel atherosclerosis, let's say, for example, an MCA clot, then you would expect the whole syndrome to you can localize that syndrome in the MCA distribution, or ACA distribution. However, cardioembolic strokes often overlap over different vascular distribution because the clot can go anywhere. And typically they present with bilateral infarcts on the MRI, involving either anterior or posterior circulation, or all of the circulation. But sometimes if you see, for example, a cerebellar stroke and cerebellar infarct, or an infarct in the frontal lobe, and frontal lobe is usually supplied by anterior circulation, cerebellum is supplied by posterior circulation. So even if it's present just on one side, there are still two different circulation, and you should think cardioembolic in the differential, if that's the case. Okay, so that's one presentation, multiple vessel distribution. The second way this can present is what's called a wedge-shaped infarct, a wedge-shaped infarct. So what are wedge-shaped infarcts? Basically, sorry, I'm getting a message from University Springs. A wedge-shaped infarct is basically, if I'm just going to quickly draw it. This is an axial section of the brain. Outside is your gray matter, and then inside you have your white matter. So a wedge-shaped infarct is an infarct that starts at the periphery, involving the cortex, but also the white matter, and extends inside like this. That's your wedge-shaped infarct. And the reason this happens is because your blood vessels make a very sharp or acute turn from periphery when they go inside like this. So the clot that comes from the heart, for example, if there is a big embolus that came from the heart, it's going to stop right here. And then it will affect everything downstream, which usually is a combination of both cortex and white matter involvement. So if you see a wedge-shaped infarct, think cardioembolic, although it's not unique to the cardioembolic, by the way. So for example, a proximal ICA clot in the neck can break off and can stop again at the turn here and can cause a wedge-shaped infarct. But when you scan their vessels, and if the vessels in the neck look clean, then think cardioembolic source for a wedge-shaped infarct. That is how they look like on neuroimaging, cardioembolic strokes. We'll just cover some common causes of cardioembolic strokes. The most common cause that we see usually clinically is, of course, paroxysmal atrial fibrillation. Some of the other cardioembolic causes for ischemic stroke are valvular disease. So, for example, if patient has a prosthetic valve, that's one thing, but they may also have rheumatic valvular disease or a history of rheumatic valvular disease. PFO, we'll come to the discussion of the PFO later, but PFO is a common cause of cardioembolic strokes. A left ventricular thrombus as a complication of MI may be a common cause of cardioembolic stroke. I'm only going to discuss common etiologies, okay, not zebras, because that's the whole point of this lecture series. You need to know common things. And some other causes are basically those that are not large vessel atherosclerosis, that are not lacunar or small vessel disease, or not cardioembolic. Let's say, for example, a young patient came in with a stroke, has no history of hypertension, diabetes, non-smoker, does not use any drugs. Large vessels look clean, and then you did the workup 2D echo, there is no PFO, no history of any of these, telemetry does not show atrial fibrillation. So then you need to think of other causes of ischemic stroke. So some of the most common quote unquote other causes, there are many, but we'll focus on few, are hypercoagulable states, especially in a young patient. If a young patient presents with an ischemic stroke without any typical risk factors, think of hypercoagulable states. They'll probably give you some history, or even if you're talking about your questions, they'll probably put some history of, for example, a history of DVTs or PEs. If it's a woman, they may give you a history of recurrent miscarriages. If you want, you can subdivide hypercoagulable states into genetic and acquired. I'm just going to lump everything together. Some of the most common genetic causes may be factor V laden mutation, protein C or S deficiencies, antithrombin 3 deficiencies, prothrombin, which is also called factor 2, prothrombin gene mutation. In female, for example, anticardiolipin antibodies or antiphospholipid antibody syndrome. So these are some of the common causes of hypercoagulable states, which is one of the other causes of ischemic stroke in absence of typical risk factors. Somebody, let's say, for example, was involved in a motor vehicle accident or any sort of trauma, or went to a chiropractor and presented with an ischemic stroke. What do you think of, especially if it is associated with headache? Dissection. Dissection is maybe a common cause of ischemic stroke in many patients. Usually presents with headache, and sometimes it can be life-threatening. How about other causes of ischemic stroke? CNS vasculitis, also called as primary CNS angiitis. This is a condition that may be restricted to the brain. So many times I see many neurologists are like ordering ANA profile and everything, which is fine, because lupus or other things may also cause vasculitis. However, primary CNS angiitis is a separate condition altogether, where there's inflammation of the small to medium sized arterioles or arteries in the brain. In many patients, the ANA profile may be completely normal. Um, the clue usually in this scenario is a spinal tap analysis, where it will show some elevated proteins, some high cells, and patients often present with a history of headache, which may be long-standing, and some changes in mental status, along with recurrent ischemic strokes. I think it may be a good idea for you guys to do a review article on CNS vasculitis. Sometimes the only way to diagnose would be like a brain biopsy, uh, but even that may always not be reliable because vasculitis may only affect certain vessels. So if you biopsy a vessel that's not involved, the biopsy may also be negative. Migraine with aura is considered as an independent risk factor for stroke, especially if you combine it with smoking. If aura persists for more than 24 hours, it is always a good idea to get MRI brain. In my training, I had an ER physician. He was actually working his shift, and I was actually a fourth year neurology resident, and he had his classic aura, but usually his aura would go away in less than 1 hour. And this time around, it just persisted for more than 24 hours. And he just thought that, I've never had this. And he actually, in the middle of the shift, he just left the shift and got admitted, and his MRI showed occipital stroke. We also had a patient here, I think was under residency service, I believe last year. She was my MA's friend, and I had never seen her, but my MA told me that she has been having this persistent aura for 3 days, which she never had before. So I said, just send her to ER and ask them to do an MRI. So she went to ER. The ER physician actually discharged her from the ER, saying that you don't need imaging. This is just your migraine aura. And the aura still did not go away after 2 more days. So this is like 5 days. And then she went back again. And then the other ER physician now decided to admit her, and her MRI also showed um, occipital stroke. So migraine with aura is an independent risk factor for stroke, especially if you combine it with smoking. Reversible cerebral, I don't know why it is doing this. Reversible cerebral vasoconstriction syndrome, RCVS, reversible cerebral vasoconstriction syndrome, maybe a cause for ischemic strokes. Again, usually patients present with a thunderclap headache, just like um, subarachnoid hemorrhage. As the name suggests, the blood vessels of the brain actually go into a state of vasoconstriction, and the term reversible comes from the fact that vasoconstriction is reversible in almost everybody by 3 months. It may reverse within few hours, it may reverse within a day, but in almost everybody, the vasoconstriction reverses by 3 months. It usually presents with a thunderclap headache, uh, along with ischemic stroke. Some patients may also have seizures at the time of presentation. Um, the triggers for reversible cerebral vasoconstriction syndrome may include drug use, like especially stimulants, amphetamines, cocaines. Pregnancy has been reported to be a trigger in some patients, and sexual activity. Sometimes near the time of orgasm, in some patients, it can present like this. I think that should be it. There are few more, but I think there should be enough. Cryptogenic stroke is, when you do not find any clear-cut explanation for the ischemic stroke. You classify those patients under cryptogenic stroke. They don't have any traditional risk factors. Um, you do workup for the other causes. You do not find any cause. You tend to classify them under cryptogenic stroke. I think it was a German study that showed this, that what they did was they discharged all these patients on Holter monitor, cryptogenic stroke patients on a Holter monitor immediately after discharge. and few months later, and then few months later. So over a period of 1 year. So not like 30 days back to back, but separated out. And they found that close to 17.5 to 18% of patients had undiagnosed paroxysmal atrial fibrillation on one or more of the recordings. So when patients present with a cryptogenic stroke, it is always a good idea to get cardiology involved and to see if they would like to do either Holter monitor recording versus or a loop recorder monitoring. I do not think they've been compared head to head in terms of yield, but either is fine as long as there is some prolonged cardiac monitoring to rule out paroxysmal atrial fibrillation as the etiology. But in many patients, you may still never find a cause of this stroke. So you just manage them medically. So that's your classification of the stroke. I'm going to remove this for now and focus on the management part or the treatment part. I think I again have a PowerPoint on the management of acute ischemic stroke, like in terms of TPA and endovascular intervention. I had given a lecture, I think 1 or 2 years ago. And I think that PowerPoint is probably in the shared folder as well. So you may want to review that PowerPoint where I've classified the contraindications and everything, TPA that is easier to remember. But I'm just gonna cover some basic things here. TPA or IV altiplase was approved based on NINS trial or study that showed its benefits. So in this study, they administered TPA to patients who presented within 3 hours of symptom onset, which is where FDA approval comes from. However, later studies, including ECAS-3, I believe, showed that TPA actually also is beneficial in an extended time period up to 4.5 hours, although FDA has not approved it up until 4.5 hours. But most other regulatory agencies in Europe have approved it
It's so
up to
crazy.
four and a
I
half
came
hours.
around work one time while I was on lecture to see the house, and lecture was on, and I was parked in the same position. It's crazy, huh? Thank you.
Hello?
Ryan.
Just kissed it.
Ryan, you're unmuted.
Dane, turn off your mic.
Can I drink cotton wine? Is that okay?
It's not working. You have to do it.
Okay.
It's because, babe, why do
I
you?
took it off Wi-Fi.
So
It's your
ECAS-3 trial
battery. It's like,
showed the benefit
babe,
up to 4.5
because
hours.
you always do
Just do it on your phone right now.
my
Who is
lectures.
this?
Ryan,
Ryan's saying you need to turn your mic on mute. I think you're okay to go, Dr. Doshi.
Okay.
Believe that the battery thing does it. It's like, look at the difference. Did you just have it?
I think I'll have to follow.
Should we check it out?
Oh, that's what AMR stands for?
Yeah.
AMR. American Medical Response.
Okay. So ECAS-3 trial up to 4.5 hours, but in US we still give TPA up to 4.5 hour time frame. Some other studies, I think a group from Australia, I don't remember the name of the trial. Probably upon or about some of these patients, we did not usually give them TPA because
Dr. Doshi, I'm sorry, I don't think we can hear you. Oh, Dr. Doshi is no longer on. Okay.
Max, I think you should finish the lecture for him.
Very funny, dude.